Do you see us and I guess probably nurse practitioners and physicians all just being called doctor? You walk in the room and say, "Hi, I'm Dr. Smith." No.
Yeah, absolutely. And I'm sure that gets every MD hot under the collar.
Doctorate programs for PAs are popping up all the time, but there is some discussion to be had about them. I'm joined today by a family medicine PA who helps run the blog, The PA Doctor. We're going to discuss the doctorate degree for PAs, why people should get a doctorate, what it means for the profession, what the different types of doctorates are for PAs, and if there should be some standardization there, and also if the profession is heading towards doctorate as the initial and terminal degree, replacing the master's degree. So stay tuned to hear some of the controversial things we're going to discuss and see if you agree or disagree. Hi, it's Michelle from the Medicine Couch. If you like what I do here on the channel and you want to help support it, please hit that subscribe button down below and share these videos with your friends. Now let's get into that discussion. Hi, Russell. Thanks for joining us today.
Glad to be here.
Russell, in addition to being a family medicine PA, you also are involved with the blog called The PA Doctor. Can you tell us a little bit about that?
Some colleagues and I decided that we needed to advance our careers and that we were going to do that by getting a clinical doctorate, but we wanted to help other people understand why we did that and to maybe take that journey with us. And then it kind of grew out of that. It's really just a place where PAs can be heard.
And when did you get your doctorate?
I finished that about 6 months ago.
Oh, congratulations. And how long was that program?
It was a year and a half at LMU.
We're going to talk a little bit later about the different options when you go to get your doctorate for a PA. But what was your program? What was your focus?
I'm quite proud of the work we've done at LMU and that LMU continues to do because it is a very robust clinical program. We spent a year and a half studying internal medicine.
Yeah, that sounds very interesting. And I guess what I would have initially pictured for a doctorate for a PA is the more clinical focus. But that's not necessarily the case for the doctorate of medical science programs out there because there's a wide array of programs for a doctorate for a PA.
Yeah, there are. And personally, I'm not sure how I feel about that because I think in order for PAs to advance as legitimate, independent clinicians, we need to have the kind of clinical chops that a program like LMU could help offer. That doesn't mean that there aren't other clinical or quasi-clinical programs out there, but there's also a lot of DMS programs that are purely administrative, or they're more about leadership and global health. And there are several programs out there that are quite proud of the fact they're not clinical at all. And so far, they're all kind of using that same name, Doctor of Medical Science. That line is starting to blur more and more. And now that there's so many new graduates and new programs, I think we're up to 10 DMSC programs and probably 3 or 4 PA specific doctorates that are not DMS. So it's evolving and it's evolving pretty fast.
When you say that the different programs have different doctorates, they're all PA specific, but they have a different designation degree than Doctor of Medical Science. Is that what you're saying?
Yeah, kind of. So one of the first PA doctorates, which is probably still one of the best ones, is a Doctor of Science in Physician Assistant Studies. Terrible name, but it was from Baylor and it was strictly a military program. And those guys basically went through a rigorous year and a half, 2 year residency with academic portions. And then they graduated with this uber long credential, DSC, PAS. Sometimes they shorten that to DSC, sometimes they don't. So the next program was Lincoln Memorial University's Doctor of Medical Science, and that was designated DMS. But then Lynchburg followed, and they preferred to add a little lowercase c after that. So theirs is the DMSC, and that seems to be the more popular one. But there's still a DPA, Doctor of PA Studies. There's a DPAS, which is another variation of that. I really wish it was more cohesive. And that, again, is kind of where the blog came in. We wanted to try and provide some direction and garner some recognition for these new credentials that patients wouldn't be familiar with.
Is there any talk that you know of within the profession of standardizing the name of the doctorate?
No, I don't think so, especially where the master's degrees have been so different for so long. I
Oh,
don't I don't see us coming together. When the profession was voting on a name change, I was honestly really hoping that we would not just take an intermediate step and change our name to physician associate, but that we would take a once and final step of changing the name to Doctor of Medical Science. And that would have provided some direction for us, but there wasn't anywhere near enough support for that.
I would think that it would be great to have some kind of differentiation between a purely clinical doctorate and the doctorates that go for the administrative track or the educational track, because those are the three main tracks, like administration, education, or clinical, correct?
Yeah, absolutely. And I totally agree with you. LMU's program started in 2016, and for a while, the DMS was the clinical, and then the DMSC was the quasi-clinical option for folks that wanted to do other things or maybe wanted to design their own clinical experience. But that's really not true anymore because High Point now has a DMS that is not clinical at all. Then you have schools like, I think it's the Rocky Mountain University of Health Professions. They offer a psychiatry track, and that's a DMSC. So we can't really even use that distinction anymore. But there are still programs like the Doctor of Health Science that
Mhm.
far predates the DMS. And there's doctorates of public health, and there's PhDs in various fields. And I do wish there was a way to distinguish somebody who had a deeper clinical training versus someone who, I don't know, maybe had a broader approach to their doctoral training.
There's a difference when you're looking in practice of somebody who's spent extra years training and getting the specific medical knowledge versus getting education or administrative knowledge. It's all good stuff, it's all knowledge, but yeah, it's different.
I think that's kind of the problem with PAs in general, though, because a new graduate PA, which is probably going to be at the master level now, except there are several schools that are now giving, I guess you could call it a bridge from a PA to DMS, where instead of 3 or 4 or 5 semesters, it's just one extra semester after their master.
Oh, wow.
But there's a big difference between new graduate PAs and PAs that have been practicing for 10, 15, 20 years. And I think that is where a lot of this discussion of evolution and independence comes from. And that's probably also where some of the kickback comes from as well, from physician groups or legislators. I don't think new grad PAs are able to transition into independent practice, but PAs that are seasoned and PAs that have extra doctoral training in clinical medicine are far better positioned to do that.
So I'm just trying to make sure I understand what you're saying is that if we're going to have programs that are going to be the initial program that somebody enters for PA, but they're going to come out with a doctorate at the end, it needs to be a substantially larger program that contains the information you would get if you did them both separately. Is that kind of what you're saying or not?
Well, I do think we need to make the doctorate the entry level degree for PAs. And I know that is a very controversial subject, and that makes a lot of people mad. And there's a lot of PAs that have been PAs for a long time, and they're excellent. They're the top of their field, and they have a bachelor's degree or they have a
Okay.
certificate that they've been practicing for 10, 20, 30 years. And again, that's kind of the whole problem with the PA profession is we don't have a way to demonstrate our growth as clinicians. And so legislators and the public look at all PAs as the same. But now with the ability to get a doctorate and preferably a clinical doctorate, perhaps there is a way to distinguish newer, less experienced PAs with ones that have more experience. And then I hope that would help to push us in a direction to where we can be completely responsible for our own decisions, and we can regulate our own profession and not have our professional licenses tied to theirs.
I went to PA school 2013 to 2015, and I remember this talk was starting mainly because I heard it about the nurse practitioners moving to doctorate, and then classmates and people are like, well, maybe we're going to have to get a doctorate one day. And I remember being just irate about that, thinking if I wanted to spend all those years for a doctorate, I would have gone MD. That was part of why I chose to go PA, because I was older and I was looking for a shorter program. Not the only reason I went PA, but that was part of it. And so I remember being very upset about that, but it's just the reality of what's happening today. So before we did this video, I went and I looked because I was curious about physical therapists. So their degree is a doctorate, and they changed theirs from a master's to a doctorate degree back in 1996. So that was a long time ago. And then the nurse practitioners, I know we've talked about it, and I know that people know about it. But I just read that in 2018, the American Association of Nurse Practitioners faculties voted, and they determined that all nurse practitioners, the terminal degree for nurse practitioner would be doctorate by 2025, and that they were going to not accredit any new nurse practitioner programs as a master's degree. If you have other professions around you moving to a doctorate, it just seems like it's unavoidable that it's going to have to happen if we want to stay competitive and make the same salaries and be able to get jobs.
Yeah, you're absolutely right. It is unavoidable. And I initially chose the PA route for the same reasons. I never considered going to medical school, never. But, now 10 years later, I guess I'm chafing a little bit and wish I might have done something different. But you're right, we are the last clinician type to not have a doctorate. I mean, we're surrounded by PharmDs, DPTs, DNPs, Audis, DPMs. I mean, you name it. Every single major clinician type has a doctorate, official doctorate, except for PAs. And I think we just have to move forward. If we don't, we're going to start losing out professionally. And that's already happening. PAs are
Yeah.
already losing jobs to NPs, not necessarily for a doctorate, but for the independence thing, which does
Mhm.
involve having a
Yeah.
doctorate.
And do you feel that that is a necessity in order for the PA profession to ever really get independence, that we're going to have to be doctorates first?
Yeah, I do. I think the name change was important because it's easy to question why an assistant
Right.
should have any sort of independence, but associate is only marginally better. But when someone has a doctorate, you're considered an expert in your field and you have the terminal degree. You cannot go any farther. And you you have a new name by virtue of holding that degree, doctor. And I feel like we will go that direction eventually, but because we have and are investing so much into the physician associate name change, it's unfortunately going to be another 10 or 15 years before we have
Mm.
the will or the political capital to do that.
But if we had changed it to a Doctor of Medical Science at this point, I don't feel like that would be fair, accurate either for all the people that have masters.
It certainly is logistically problematic, and they would have had to pick some future date to make the transition. And like the NPs, they would have said, this is our terminal degree, and from this point on, and then they grandfather everyone else in somehow or wait for us to transition. But they've already done that. I mean, the same thing happened with master's degrees. We all had bachelors until they decided the master was necessary. And then we all caught up, and those new students just started getting a master's. So we've done this before, and we're going to have to do it again in the future. And I wish we would have just done it now, but there's going to be so many PAs getting a doctorate, and especially the doctor of medical science, that eventually there's not going to be much discussion. Most PAs are already going to hold doctorates because,
Yeah.
gosh, I think the University of Lynchburg just graduated 250
Wow.
DMS PAs, and they do that like every semester. It's a big program, and there's 10 DMSC programs right now, if I'm not mistaken, and there's going to be 10 more in a year and 100 more in a couple of years. And so eventually it's just going to happen.
Do you see us and I guess probably nurse practitioners and physicians all just being called doctor? You walk in the room and say, "Hi, I'm Dr. Smith," or
Oh, yeah.
whatever. Yeah,
Yeah, absolutely. And I'm sure that that gets every MD hot under the collar, but we already see that with orthopedists and podiatrists, ophthalmologists and optometrists, ENTs and doctors of audiology. I mean, there's already kind of a pecking order of doctors out there, and they've gotten used to it. And I think they're going to get used to us being called doctors when we have doctorate degrees. Before I went back to school, I guess I felt differently about this. But doctor is not a profession; it's an honorific. It's a sign of respect. But opponents claim that that will somehow be confusing and misleading. But I don't think people confuse the podiatrist for the orthopedist or the optometrist for the ophthalmologist. They've figured it out. And credentials should always be displayed, and they will always have to be displayed. At this point, nobody really cares whether their physician is an MD or a DO.
right.
And I think in the future, after many things have changed, they may not really care if their doctor is an MD or a DMS or a DNP. I don't think that's the case right now. I don't think our training really can challenge that of physician training, but there needs to be a way to recognize PAs that have been in practice for years and are growing and evolving and are now just as capable, if not more so, than that new grad MD.
When you did your doctorate, since it was, clinical, I assume that you had rotations and things again, or how did that work?
Well, I did a hybrid program. So most of our discussion was through forums, through weekly meetings, conferences, or grand rounds. And then we spent some time on campus as well. I don't know if I'd call them rotations, but the program was divided into organ systems. So we spent 5 weeks in cardiology, 5 weeks in pulmonology, 5 weeks in gastroenterology, so on and so forth. And we would meet weekly with a physician trained in cardiology, gastroenterology, et cetera. Our class had 25 people, and we were all divided into small groups, and we would get case studies that we would work on throughout the week, and we would go on to message boards and post answers to the questions that the physician would post to us. And so there was a lot of back and forth during the week. And then on Sunday, we would spend a couple of hours, and one person from each group would present their case in kind of a grand rounds type of format. And then the physician would comment on it and share his thoughts and experiences. So in that way, it was a sort of rotation, because then after we finished one unit or one rotation, we moved on to the next.
So there wasn't any like physical hands-on, like increasing your exam skills, seeing things that maybe you've never seen in clinic or anything like that.
Besides the ultrasound training that we did with a radiologist, I didn't take time off work to go follow a cardiologist. That may be considered a weakness of the program compared to the way physicians are trained. But I would also argue that, over my 10-year career, I've seen tens of thousands of patients. And so I have a foundation to apply that knowledge that I'm reading or learning about during the week. Our core text for the program was the American College of Physicians MICSAP training. It's a board prep program for internal medicine physicians. And we would read every single chapter pertaining to every single organ system, the same thing internal medicine physicians were studying to prepare for their boards. And so even though I didn't take time off work to to do that, I still feel like the education was valuable.
Yeah, and I'm not doubting that the education wasn't significant. I'm thinking about from my point of view. I did not have some of the greatest rotations when I went through PA school. So there's a lot of hands-on stuff that I feel like I didn't get. And then also if you don't have a rotation like in orthopedics, if I'm going to call myself a doctor, I want more hands-on training. I guess I just figure like if we're going to move more clinical and we're going to call ourselves doctorate, I just see it being like almost end up being like med school, but we just don't have the mandatory residency when you come out.
No, you bring up a really good point. And right now, I don't think the DMS is a good entry level program because of the way that it's currently formatted. It's really kind of meant for seasoned PAs
Mhm.
who already have a foundation to, kind of polish up their knowledge base and build it up a little more. So for someone who comes out of PA school at this point, or, even in the future, I think that's really what a residency is intended to be. It's where you take all that book work and all those skills that you have learned, and now you put it into practice by seeing patients, and then you have an attending who kind of keeps an eye on you. So some people will say that that's really the way PAs operate the rest of their career. They're basically in a residency type format where they're using what they know, they're learning from colleagues, and then you would think that there would be continued opportunity to progress, but there isn't. The seasoned PA is going to stay in that residency format after 30 years, and that's just ridiculous when we're in a physician shortage. So yeah, if it does become the entry level degree and we do become an alternative type of physician, then I think the clinical portion has to be increased or improved. But would we then also adopt a residency and basically follow the DO route of being an outsider, being scorned by MDs, and then eventually becoming so similar that we're accepted as equals? That honestly might happen in 50 years, 100 years. That might be the way it pans out. But the whole residency thing is a huge bottleneck. There aren't enough residency positions for the people that do graduate medical school.
Yeah.
And if we just tried to create our own, I think we'd be in the same boat. So there is a place for a non-residency trained doctor. I really do
Mhm.
think that is true, but there still has to be a way to prove competence, and it just doesn't have to be the existing system.
So I think you're right that you don't have to have a residency when you come out. I think that the PAs that are out there practicing today, I think we're really well trained and we come out and we are able to hold our own and do a good job. And I think studies have shown that. But I feel like in the past there was a lot more nurturing when people came out. There was a lot more mentoring. There was that tighter physician relationship. Physicians owned their own practice. They had more incentive to help train. I feel like that as medicine becomes more and more of a business and we move away from that model where physicians are now employees and a lot of times they just kind of get saddled with being a supervising physician because that's what administration tells them they need to do. I do worry about that and wonder if, in order to feel competent for themselves, if PAs are going to be searching out residency more and more.
I completely agree with you. But I also think that a person should be responsible for staying within the bounds of their own training. I mean, we are the only professional who is tied to another. Even in healthcare, you don't see respiratory therapists or x-ray techs or nurses or nursing assistants or anyone like that tied to any other profession, even though they don't have the same level of training as a PA or a physician. They're expected to do what they can do and do what they know without going beyond. I think we are capable of staying within what we know and doing what we know. And when there's something that we don't know, just like any physician who's in a general practice setting, you either go research it, you call someone, or you make a referral. Because of what you've mentioned, the fact that the employment landscape is changing and more physicians are employed, and more PAs are employing physicians and other PAs, I think we really need to be once and finally distinct. The whole idea of supervision is all an afterthought anyways. I mean,
Yeah.
if it happens at all, it happens after the patient has been seen. It was collaboration from the start, and as a PA gets more and more seasoned, that even that becomes less and less. But
Mhm.
yet, if that physician loses his license or passes away, the entire clinic closes, and
Yeah.
all of those patients go without their health care because the PA cannot continue to do what he's been doing for the last number of years.
I have to laugh sometimes or get very frustrated when I see discussions after articles about PAs and NPs looking for independent practice. And the discussion comes up, it's like they need to be, they need to be under the supervision of the physician to, we save them from making all these mistakes. These are usually physicians talking. And I think to myself, and I think back to all of the places that I've worked, and the physician had no idea what I was doing all day long. And if I had questions, which I did, I would go to them and I would ask them, or I would tell the patient I have to call them back after I had a chance to, discuss it with the physician. But they didn't know. So I don't know what these people think that put up this argument. If they think the physician's just, standing outside the door and like waiting to see what we did. I mean, it's like we practice medicine by ourselves, basically.
Yeah, there's already a massive shortage of physicians, and they're already chafing at the amount of administrative load being placed upon them. And then there's these people advocating that they supervise other people and take responsibility for their decisions with which they have nothing to do. It makes
Yeah.
absolutely no sense whatsoever. I am 100% for having graduated responsibility. A new PA should be mentored. And I think Utah really has the right idea in that a new graduate PA has to either be in constant contact or collaboration with either a physician or an experienced PA. And then after I think 5,000 hours or 2 years, they're able to then be licensed and practice independently. But what does that even mean? Like, opponents would suggest that practicing independently means that you're going to be off in a vacuum, doing all of these wild things that you weren't trained to do without consulting anyone. And that's completely ridiculous.
Right.
Medicine is a team sport. When you're in general practice, you lean pretty heavily on people like general surgeons and cardiologists. And we still have to refer to the nephrologist when the patient needs dialysis. We're not going to try and somehow step out of this network or the system that's been developed. So I don't understand that argument either. I mean, we
Right.
would simply continue to do the work we do without having all of the administrative headache
Right.
and the risk of losing jobs and livelihoods if something happens to the physician license with which we are associated. And that is partly why I get so fired up about it and want to be involved in advocacy, because it's very easy to make PAs look bad. It is very, very easy when you start talking about how, well, PAs only go to school for 2 years and physicians, it takes 10 years to become a physician. I don't think that's a fair comparison for a number of reasons, but yeah, we're easy targets, especially when we're called physician assistants. I mean, I don't know of any PA that actually assists a physician except in the operating room. A name change was long overdue, for sure.
So we've talked a lot about PA doctorates. Do you have any more thoughts about it that you'd like to share?
Why get a doctorate? Because we've talked about how there are plenty of seasoned PAs out there, or really even PAs that just chose this route for a particular reason, and they have no interest. They don't see the need, and they're quite bothered by the fact that we're moving this direction. But I think first and foremost, getting a doctorate is for personal growth. If someone asks me, why did you do that? Like, what benefit do you get? The first question they ask is, are you paid more? Do you make more money? And the answer is, I did it for me. I did it for my patients. I wanted to be a better clinician. That is really the only answer or the only response that I feel like I need to give. But I think there already is an opportunity for doctoral PAs to advance in their careers, whether it's inside of medicine, where it's a transition into administration or leadership, or working for government or NGOs, whose pay scales often depend on level of education. But right now, financially, I don't think it makes a lot of sense. I'm not paid more for having a doctorate. Insurance companies at this point don't care that I have a doctorate, so my reimbursement doesn't change. But I'd like to think that I can now work more efficiently and be more productive, and that certainly does pay off.
Well, that was quite an interesting discussion. There is a lot of things happening in the PA profession right now and a lot of things to think about. So, thank you so much, Russell, for sharing with us your thoughts on the doctorate programs for PAs.
Pleasure to be here. Thank you.
It's interesting to me what Russell brought up about the different doctorate degrees for PAs and the way that the different programs are structured. It's something I haven't given a lot of thought to, but I can see it being kind of problematic in the future if we don't get on the same page and start standardizing things and coming up with very specific degree programs. A lot of kind of controversial and difficult stuff. Let me know down below if you agree or disagree with what we're saying. If you're curious and would like to learn more about what the DMSC program entails, I have done a previous video where I interviewed Dr. Randy Danielson. He's director of the PA doctorate program at A.T. Still University. You can click on that video here. Thanks for joining me today, and I'll see you next time on the Medicine Couch. Bye.